the introduction of objectives. So I just want to point out a couple of things. Last 21 to 22, the Health and Safety Executive reported that work-related musculoskeletal disorders cost the UK around £20.7 billion. And that includes treatment, time off, whatever, compensation, and so on. And that was correlated mainly through RIDDOR. So I think it's an underestimated number because I know that RIDDOR isn't followed that well, especially when I investigate. But that's a different presentation for a different day. Moreover, I'm going to change this to NHS Resolutions England, actually. But NHS Resolutions reported for the UK 13.8 billion. And what Resolutions does, is any compensation paid out to patients or employees or lawyers related to work-related injuries or injuries in general was £13.8 billion. To put it into context, the budget for NHS England was £3.2 billion last year. The budget for NHS Resolution England was £6.8 billion. So if we reduced that cost by risk assessing, reducing the cost, training and everything else, we could triple the NHS England's budget. And hopefully, rather than add more middle management, that money would go to actually more staff, more resources, more education, more protected education days, and so on. I mean, just imagine what we would do if we tripled the budget we have now. So that's so if you need a reason as to why you're here and why this is being driven, it's not just me. The government has no more money. They want to reduce resolution spending so that they can put that into the NHS. So change is coming, trust me. And it's good that you're here because you'll be at the forefront of that change. So the objectives today is to, this is part one, by the way, and in the next slide, I'll get onto that. How to conduct a weighted formal risk assessment. Now, I'm using manual handling as an example, but it could be anything. It could be patient related. It could be, I think there's a lady from London Borough Councils here today to see how they can risk assess their clients, which is, immigrants, vulnerable people, so they can better streamline their process for finding accommodation, because that costs a lot of money too. So this could also be OTs for risk assessing homes, what equipment they need. So this can be anything, but I'm doing it under manual handling format because we're MBE. So, but it's not limited to that, is my point. And then take a quantified risk assessment and give it a realistic risk of the probability of injury and kind of the science between that. But I won't make it too complicated, I promise. And then how that risk assessment can be used to drive change and also drive your training, because I've had a lot of questions from the last presentation around training and content of. So I'm going to touch on that also. So let's move on. So I've also written a paper on this presentation. It's being peer reviewed and it's part one. Part two is the actual next step. So once you've done your risk assessment, what do you do with it? And that's what part two is. And part three is then once you've written your interventions based on your risk assessment, how you then implement those interventions, and then also how you train. So that's on adult healthcare professional education. And there I explain my conceptual framework of knowledge and mobilization, which is also a publication. But really, you can't, in my opinion, part one, two, and three, they go together. And so if you want part two and three, then tell the MBE so, and I'll come and present it. And I think that if you can understand what we're doing in part one, and two and three will be easy. Part one is the hardest part, honestly, and that's because there is a bit of we talk about probability, risk, hazards, what is a risk, and so on. So I hope that makes sense. So let's move to the next slide. So this is a case study, and it's on radiology department in a trust. It's not a real department. It's just a case study, and it's I've made it. It's based on a risk assessment I did, but I've changed everything, so it's not giving away state secrets or anything like that. But So it's a radiology department, and as we know, of radiology, there's lots of different sub-departments. There's MRI, CT, interventional radiology, and so on. So at this point is where you have to make a decision. How am I going to risk assess this department? Am I going to do a global risk assessment, or am I going to go department to department within the department and then make a generalized report? And that really is up to you. However, I think it's better to break down a large department into services, which is what I've done, and then you've covered all the potential risks because each service is different. You know, X-ray film has different risks than interventional radiology, where you're proning patients. So that's the approach I take. The second point I want to make is work smart, don't work hard, and that's what my method is based on. And I developed this method in 2010 when I had to bring down surgical site infections. So as I go through, I'll bring it back to this is how I know it works because it did work. So and also allow me to work smart and not too hard. I hope you understand that as we go along. So the first thing you've got to decide on, let me see here. Did I say it here? Yes. So the first thing you have to decide on is what is your research question? And I say research question, it's because I'm a scientist and in my PhD and MSc, which is a derivative of what we're doing here, is what is it I want to know? What is it I want to know? Because maybe we already know it. Maybe someone's done a risk assessment and I don't have to do it, for example. Maybe someone's done that study and we know that marriage is good for you. You know, as an example. So what is it you want to know? So when I went into radiology, I wanted to know what the overall risk was in the Department of Radiology and what are the risks in specific services such as MRI and X-ray. So that's my research question. That will drive my formal risk assessment because there is no template for my variables. It's all to do with the workplace that I'm risk assessing, and that's really important that we. So when people ask me, "Can I have a template risk assessment, please?" I'm like, "Sure, but it won't help you." You have to decide what your variables are, and that's why it always starts with ethnography. All right. So what we're doing is we're phenomenologically investigating the department, i.e., I'm observing each service, the procedures they do in there, the MH procedures, and so on, and then the risks. And then I engage staff in a discussion. Why do you do it that way? Do you risk assess? And when I say, do you do Tyleo risk assessment? Often they say, what's Tyleo? So there's a good risk we've identified right there. And then what beliefs, challenges, how, I always say, if you were in charge tomorrow, what would you change? And I say, what do you think the biggest risks are? Because I'm working smartly, essentially the staff are telling me what the variables should be in my risk assessment. So right there, I've got a head start. I know what it is. Also, before I go in there, I have a chat with the overall senior person in that department and see what they think the risks are. So I've got a really good idea of what the risks are before I walk in. And also being a clinician and having clinical experience will give you a huge advantage here as well, because you already kind of know what the risks are. But it's not essential because you can learn and educate yourself up to that level. So none of these things that I say are absolutes. It's up to you. But the first step is ethnography. Always go in that department, go in that MRI room, go in that, as I did, interventional radiology. Talk to the superintendent, talk to the staff, establish yourself, right? And I always say, I'm here to help you. I'm your friend. I'm not here to judge you. And I offer immunity too. Whatever they tell me goes no further, and it doesn't, but it drives my content of the risk assessment. So I hope that is better explained than my last presentations, because I had a lot of questions around that. So I'm trying to explain every step really as well as I can. And again, so when I observed the various services, a couple of things really stuck out to me. Is that lateral transfers are done with 2 staff, prone positioning is chaotic at best. And it's a danger to the staff and the patient, and I will say now, as I get constantly, I get challenged by my directorate saying, is this MH related or are you offering clinical advice? And I say, I always answer the same way. And And as you can imagine, I'm really popular with my director. I'm not, by the way, for this reason, because I say, well, you can't separate manual handling from patient care because manual handling is the only thing that's legislated in the hospital. Apart from fire, everything else isn't. So what we decide in manual handling will have a huge impact and a ripple effect, like throwing a stone into a lake, on everything. And I tell you what, it does. If I want change, that's what I do. So prone positioning. If we just take that little thing, the question is, how do I figure out what the best prone positioning is? Because remember, our risk assessments are then legally required to have advice to minimize those risks. So it's not a simple it's not a simple procedure, but this is the first step. And then part two is where we get into how to give that advice, whether it's standard operating procedure, writing a moving and handling standard operating procedure for radiology, and telling them how to prone position. Because then you've got to decide what the best technique is. And trust me, I'm just coming out of that and I had a hard time. Should I follow the operating room technique of proning? Should I follow ITU technique of proning? Should I get expensive equipment in? Like these are things, but your risk assessments will drive that. Okay, so this is the point I'm trying to make. This is your risk assessment is driving everything you do after that, including training, which we will get into in a minute. So these are the common things I found, stand aids and so on. The next part is step two. So this is the formal risk assessment itself now. So I've observed, and guess what? I do this at home. I do this at the office because I've got everything I need. I'm taking copious amounts of notes on my pad the whole time. So now I decide what my variables would be for the risk assessment. Obviously, I'm keeping in there core, moving and handling known risk factors, but I'm also adding service-specific risks so that I get a proper prediction of risk when I do my probability modeling. So I use the step two, which is putting it into a formal risk assessment. I do the risk assessment, and then that will guide my plan of action of how I'm going to reduce these risks to the minimum level as reasonable, practicable as I can within the law. And then I write a report and advise. I never tell. I'm only advising the manager, the superintendent, the 8B, the 8C, the director, whoever it is I'm talking to. I'm advising, I'm not telling. It's up to them if they do it or not. But dollars to donuts, they'll do it because I've done everything for them. So why wouldn't they? But that's a different story. So, and then part two, I actually tell you how to do that. So part one is this how to do a risk assessment, and part two is how to do that. So you can see that part two is quite important too. But this is part one. So now let's get into that properly. So, so again, what is it I'm asking myself? So I went in there and I wanted to identify the risks, right? And then what's my objective? My overall objective is to improve staff safety, which in turn should, in theory, at least improve patient safety, which should in turn reduce work-related injury, sick time, and reduce trust being sued. So we're going to get that NHS resolutions bill down, right? One person can't do it. It takes everybody in the NHS to work towards the same goal, but you'd be amazed how quickly it happens. So what are my variables going to be? So these weren't my, so these are my health and safety executive guided variables, which I think if you're doing manual handling risk assessment need to be in there because they are the known risk factors. So I always have holding loads away from torso. Well, guess what? When I was in the operating room and staff are preparing a patient for the lithotomy position, they have to remove the end of the bed. It weighs a ton and only one person can do it. And then they've got to carry it 8 feet and put it on the floor or wherever they're storing it. So again, I think that's important. Twisting, yes, stooping. Well, if your room isn't set up, in your operating room again, if the room isn't set up properly, you're stooping. In radiology, there's equipment everywhere. So if it's not set up ergonomically, you're stooping. So I just recently designed a survey for occupational health, trying to understand what we can do better. And The reason they asked me to do it because their first survey had no responses. And when I looked at it, I understood why. Um, each question has to be there for a reason. It can't be a tick box exercise. So if you're asking, for example, what band you are in a survey, it's got to be there for a reason. Is it because the lower bands carry more risk? And that's so this research philosophy you have to bring into your formal risk assessments, I believe, so that it's not there's no unnecessary information in there. So constraint on posture. You know, these to me, these are the core things I have in every single one of my risk assessments. And then for radiology, I brought in patient positioning specifically, and then specific variables when I was doing cardiology risk assessment. Hardwired telemetry was something that I noticed in step one, my ethnographic investigation. So I included it into my risk assessment because that way we get a clear, adequate reflection of the known risks. Because again, this is our baseline measurement. This is our, I can't make this clear enough. This is our baseline measurement. So whatever we find here and however we quantify what we find, when we return in 3 or 6 months, we have to know if there's a difference or not in what we've done. And that's how you do it. You compare to baseline. So if we capture everything we can in baseline, then our measurement equation, which I'll show you, is geared to be incredibly sensitive, so we can know instantly if we've made a difference or not. So it will go up if we have, it will go down if we have, and it will go up if we haven't. So this is really important if you're going to do it, in my opinion, if you're going to follow this framework of modality that I use. So I can't give you a generic risk assessment because that really has to be up to you, if that makes sense. So the next thing is you add it up, and then you have, say you have the top score is 110. So if you score less than 30, then that's green, low foreseeable risk, and then that will give some, this is very generic. You write in there whatever you want, by the way. Yellow is 41 to 60 when you've added everything up, and that's, you know, medium risk. Maybe you should get some attention and help. If you're over 61, my friends, then we've got an issue, because I've specifically written the risk assessment to capture all the risks. And so that's telling me, that's red because it's telling me we've got to step back and think about this because someone's going to get hurt. So I hope that clears up the variables I'm using. Have the standard generic variables, please do. I'm not saying don't do that, and go to HSE for that. But what I'm saying is don't tick box it. Just don't download templates. Add in everything that you've identified in step one, which is your ethnographic investigation. So your risk assessment should have all these variables and then everything else. And then also it's weighted because if there is holding loads away from the torso, is it 1 low risk, 2 medium risk, 3 high risk, right? So then you score it 1, 2, 3, and that's what you add up at the end. I've put, if Tyleo risk assessment isn't being done, then that's a 6, because in my opinion, that's double the risk of everything. Because if it is being done, that automatically lowers the risk of everything. That's just what I do. Please do whatever you think's best, but please is your Tyleo risk assessment being done? Because I think that's underpins everything that follows, if that makes sense, including training when we have a little discussion on training. So then I include remedial steps that should be taken. And, you know, these are generally you're dealing with board managers and department managers who are busy people with massive workloads. So I try and keep it manageable. And then I always put who's responsible for this. So of course I try and include the manager, but also myself and the team, right? To try and, because that's our role, that's our job, is to support. So I always try and include that. Don't make it too crazy. I put like 5 points in of remedial steps that should be taken. Like, and this is like straight away. Ideally, if we score high, and then I put a timeline in there. But again, it's really up to you. I can't really give you a template because this is dependent on your work area, as it should be. If it was all templates, then I wouldn't be here. Right? It'd be easy. So the next thing is, so yeah, everything I just talked about. So I recognized lateral transfers, for example. So then I rationalize the risk by saying, look, there's excessive reaching, pulling, bending, awkward posture, excessive load. Where the location is, well, back, shoulders, hands, and knees. So then I say, well, what are the essential elements of this moving and handling operation? So for interventional radiology, ICU, or the operating room, those are the three main places you're going to be proning. You're going to be doing lateral transfer, under pressure with very sick people because they tend to have airlines. So you've got to take that into account, and then you've got to make sure the body's aligned when you do it. So then I do task recommendation. So I say minimum 3 caregivers, and this is intended to include radiology at night where there's only 3 people. So I say we break it into 2 halves. 2 people push, 2 people pull, head or feet, whatever you need. But it allows 2 people to push, stop halfway. The third person comes around, and then you've got 2 people pulling. And I put that in there deliberately to cover radiology, because I can't put 4 as I do for theatres, otherwise I'm contradicting myself. So you've got to also think about the macro policy you're influencing, because everything you do will have an influence on the macro policy. By that I mean the trust policy. Trust me. I've just been running into this. I've just run into this now. So that's my main advice. Okay, and also I go to published standards for this. So I looked at theatre standards, AFPP. I looked at the ICU college recommendations. I look at published literature. What does literature say? I look at policy in the trust, and I look at standard operating procedures in the trust. Because again, I want to make sure I've got the right information. I'm not contradicting, and it's a standardized message I'm giving. So that then drives the detailed advice of the risk assessment. And generally, it's always the same thing. I advise, I don't know what it's like in your trust or your workplace. Maybe, your workplace is fantastic, which is great. But for me, it's always usually the same advice. I'm going to conduct policy analysis, case law analysis, contemporary literature, and national guidelines analysis to give you what I think the best way to do something is. And that way, it's evidence-based, all right? Everything we do has to be evidence-based, even as moving and handling, facilitator, advisor, manager, whatever you are. Health and safety too, right? So I take this and I always say, let's make it a standard operating procedure, and we'll call it the radiology manual handling standard operating procedure. And that way, everything in there is the evidence-based for each manual handling operation, from standing a patient up, strength testing, TILEO, lateral transfer, proning, everything, right? And that way we've got something, new staff coming in, have a resource to see how it should be done when the superintendent isn't there. So think long-term too, because it's easy to make changes, it's hard to keep it going. So make work easy for yourself. Remember, work smarter. Get an SOP down so that when you come back, you've also got a guide to work towards, if that makes sense. And I always say, look, and I advise a work-related musculoskeletal disorder algorithm. And in that, there's 2 risk assessments. One is you come to me injured, and again, it's weighted, and then the weighted score will advise you. And also, depending on the scoring, there's a modified work duty risk assessment, which again is weighted and will advise you. But, these are examples of how you can use your risk assessment to drive change. And I guarantee you, when you start introducing SOTs, people take notice, and before you know it, that vacuum of trust policy or whatever policy, wherever you're working, will be filled. Because what you're doing is how you change culture is you're bringing up everyone around you to meet your professional standard. And that's what's happening, and that's what changes. So that's why I do this. Some more bariatric classification is another one so bariatric policy I always recommend and suggest, followed by body habitus classification, and so on. So these are just more examples, but I hope you're getting the point by this point. So I'm going to move on to part 2 now. This is where if you can nail this, you are now an advanced practitioner, in my opinion, because you're taking a risk assessment and you're modeling it to give a adjusted risk, and you're using it to drive change. And now you can see what your changes if they're working or not, because of you've got something to compare in a very sensitive model. So this to me is what's really going to make the difference. So let's start from the beginning. Let's start from the beginning. So as I said, that's our baseline. Now we're getting into how do we measure the outcomes. So the interventions that we produce, SOPs, advice, that's what I call measurements. So I want to evaluate my measurements because, you know, legally we have to. It says that in the Management Health and Safety at Work Act. It says that. So how do we do that? Well, I'm going to show you the best way to do that. And this is what I did for reducing surgical site infections and what my PhD thesis was based on, which was probability risk simulation. And guess what? I'm going to teach you how to do that in 25 minutes. So here we go. So please ask as many questions as you want as we go along, and I'll address them. There's no such thing as a stupid question. Please ask, because this is I won't be here after today to answer the questions. So what do we do? So here we go. So this is a good example of predicting risk, and this is an odds ratio. So let's imagine it's called a contingency table. So when in my master's of epidemiology, this was like 101, and this is such a superb tool, I think. It's also hypothesis testing. Some of you who are very up on their statistics will recognize this as a hypothesis test, and that's exactly what it's also used for. But let's say 200 staff out of 200 staff, 120 have been injured during a manual handling maneuver. Let's say it's radiology and it's lateral transfer. I know it says hoist at the end, ignore that, that's my fault. So then we make a contingency table. So what we're saying is, of that 120, we're going to break it down further. So 90 were injured, yes. 90A is were injured and did not use the lateral transfer two-stage technique, okay? 110 were not injured and therefore did not use the lateral transfer technique and were not injured, okay? Not 30 were injured and did use the lateral transfer two-stage technique. 170 were not injured and did not use the lateral transfer technique, okay? Then we do a simple equation of A divided by B divided by C divided by D, and that'll give us our odds ratio, all right? Which is 4.6. What does 4.6 mean? Well, if your odds ratio is under 1, then it's protective. It depends what we're looking for. But if we reversed it, we'd find it would be 0. something, saying that doing the two-stage lateral transfer is protective. Odds ratio 1 means it has no influence and is like, let's move on, that didn't work. Over 1 means it affects the outcome. So we can say, if you do not use the two-stage lateral transfer technique, you are 4.6 times more likely to get a manual handling injury than those staff that do use the two-stage lateral transfer technique. So if you are meeting a lot of resistance about change, this is a great way to convince somebody it's a right thing to do. Because A, they won't understand it and won't want to argue with you and therefore accept it, or B, understand it and realize it's a good thing. But either way, and surgeons love this, okay, because they are very, very good on epidemiology. Confounding, but please, this is unadjusted. We haven't adjusted for anything, so confounding. So be careful of confounding. Make sure that you're not confounding your results. And what I mean by that is that a famous study, this is one we use in epidemiology to show confounding. It showed that coffee drinkers were 7 times more likely to get lung cancer. What they didn't account for was a confounding factor that coffee drinkers tend to have a cigarette at the same time. That was a confounding factor. So it's not coffee that causes lung cancer. Okay, so the confounding factor was smoking. You're more likely to get lung cancer if you smoke. So I hope that makes sense. And that's what I mean by adjusting. So when we adjust it, we're adjusting to make sure we're not guilty of confounding. Okay, I hope that makes sense. So and if you really want to do in-depth analysis with adjusted modeling that does adjust, you need to do a logistic regression, which is that's my go-to model, and that is quite advanced. I'm not going to get into it here, but just there is a model to adjust for the confounding. Okay, so let's move on. So on the left here, we see probability. For the X-ray room is 0.64. Anytime you talk about probability, it has to be less than 1. 1 means it's going to happen, 0 means it will never happen. However, it never happens. You never get 1 and you never get 0. You get somewhere in between. Therefore, when we talk about probabilities, please refer to the decimal, 0.64. Okay, and I got 0.64 by adding everything up and then dividing by the total. Okay, or you can add everything up and boom, there's your probability. And if it's 100% or 1, we've got a problem. To be clear, we've got a real problem and we have to do something straight away. So that's 101 probability. 0.64, we get that by adding up our weighted variables from our formal risk assessment, and that gave 64 for X-ray room, which is our probability of risk. 0.64 times it by 100, and we get percent, 64%. Same as CT room, MRI, interventional radiology. And I did see, I've got a really good manager in the audience, Gary Latouche, who we've just been through all this with. So Gary, thank you. You're an inspiration. Gary can tell you all about this because we went through it and we found some big risks. Anyway, so getting back to this, the probability is our scores from the formal risk assessment, all right? But they're confounded. They're not adjusted for anything. So there is risk of confounding. So we have to adjust for that. And that's what we do next. And we do that using Bayes' theorem. Bayes' theorem is conditional probability. All right. So what we're doing is we're saying the risk of CT, we're saying the risk of X-ray room injury is 0.64. We're going to use conditional probability to measure within, i.e., we're going to compare the X-ray probability of risk to every service. And then we're going to compare it out. We're going to compare the risk of X-ray probability to the trust. So we do a within analysis and we do a without analysis. And that will then give us the adjusted probability of a risk. And it should be a lot more realistic. And I'm going to show you how to do that now. So I hope this is making sense now. So I love Bayes' theorem, but I do understand it gets a bit confusing. So let's do an example. So I have a headache and a sore throat. And I know that people with the flu have the same symptoms roughly 90% of the time. In other words, 90% of people with the flu have the same symptoms you currently have. Does this mean there's a 90% probability I have the flu? So this unfairly, all right, is used on physicians, and it's used in their epidemiology exams because, and 90% of physicians always say, yes, that's correct. I got 90% chance, but they haven't accounted for it, right? Which is the wrong answer. So, don't worry too much. It is, but imagine I'm asking if I have these symptoms, headache and sore throat, do I have the flu? And the literature is saying, well, yeah, there's a 90% chance of flu. Substitute flu with risk. All right, that's what I'm saying. So we do a bit more research and we find research article that says 5% of the population will get flu each year. So the probability of having the flu in general is only 5%. It's getting more complicated now. Then you spot again that research says 20% of the population each year will have a headache and sore throat at any given time. That isn't flu. So if we say the chance of having flu is 90, if you have these symptoms is 0.9 or 90% probability, we're guilty of confounding and we need to adjust for a real world answer. Okay. So the way we do that is, okay, right, now we've got some statistics. We've got something to work with. So we know we have 90%, 5%, and 20%. So what do we do with that? We put it into the equation, Bayes' formula. So the answer I want to know is P, flu, line symptoms. And so to do that, I take symptoms of flu, which is BA, which is 90 or 0.9. And I times it by P flu, which is 0.05. And then I divide it by the symptoms, which is 0.2. Okay. And then I get 22.5%, or I get a probability of 0.225. So you see, once we've adjusted for inside and outside, we've now got a more realistic chance. Risk, is this the flu? And it's actually not 90%. It's 22.5%. Okay. If you're not with me, type the question and I'll go through it again at the end. I'm going to make sure we have lots of time at the end to go through the questions. Okay, so please ask your questions. If you get this, great, well done. Awesome. If you don't, it's okay. It's okay. It's a very non-intuitive way to do things, but it's perfect for what we want to do. You might recognize this also as sensitivity and specificity testing for medical tests. So, for example, prostate-specific antigen test. This is exactly the same formula to assess true negatives, false positives, true positives. This is exactly the same thing. Also, if you're from financial world, you'll notice this is how they decide if you get credit or not. They adjust for all the known factors. It's exactly the same thing. All right. I'm not reinventing the wheel. Remember, I said work smart. Well, it's already been done, and I'm giving it to you now for risk assessment because it works perfectly. So, moving on. So, let's now apply it to our risk assessments. So, let's take the X-ray room. So, in order to do that same equation, I need to know what the trust injury rate is. So what I did is I took 12 months of Datex and I broke it down into manual handling injuries and divided it by the amount of clinical staff we have, and that gave me the rate. Remember, anytime you take something and divide it by the total, you're getting a rate, which is what probability basically is. So according to that calculation, 6% or 0.6 probability of getting injured at any point by anyone within the trust if you're clinical. That's our starting point. The next thing is the probability for any staff member in the radiology department. So I took all the unadjusted probabilities, added them up, and divided it by the number of services. All right. And that's how I got 0.62. And then and then I need the X-ray room, which is 0.64. And then I adjust for that in my equation. So at the moment, the risk of getting injured in X-ray is 64%. That's very high. But when we adjust it inside the department and outside the trust, we end up with 6%. Well, I can stomach that because actually that's bang on in line with the trust rate. So the higher the risk we find in the room, the higher the adjusted risk will be. I will say you have to bear in mind, I don't know if I say it here, I haven't. So you have to bear in mind here that the trust overall rate is the modifying factor because that's what we're timesing the X-ray room rate by. So this is why I love this model, and I hope you appreciate this now. As the trust risk rate, 0.06, goes down, our adjusted risk for the X-ray room will go down. And as our interventions reduce risk in the X-ray room, the X-ray probability, when we formally risk again, will go down. And that way, when we come back in 6 months, we expect to see 4%, not 6%. If we see 4%, we know our interventions are working because I haven't adjusted for specificity. I've only accounting for sensitivity, and we've got an incredibly sensitive model now and a great way to understand what we do, how what we do affects safety. And you can do this for patient safety, as I did for reducing surgical site infections. You can do it for anything. It doesn't have to be clinical. It doesn't have to be patients. It can be immigrants finding accommodation. That's how you adjust what you do. I love it. It's so sensitive, and that's what I've designed it to be. If it goes up, great. If I come back in 6 months and it's gone up to 10% after adjusting, that's great, because that means that people are now reporting more. So the Datex has gone up. So the trust rate has gone up because that's the modifying factor. That's the mediating factor, right? Now, if I come back a year later and it's gone up again, that's bad. That's bad. We've got to do something. But when I come back a year later, it should be down to 2 or 3%. So I expect it to go up. And that's what the distribution will show us. It will show us go up and then it will go down. And it's those outliers we can't adjust for in the distribution. That's great. We don't want it in the 75% of the. I hope you're seeing now that if you do your formal risk assessment well, you choose your variables well, it the knock-on effect is your sensitive model will show that, because everything we do should make it go up, and then it will settle and go down. But this is how we measure our outcomes, and this is what isn't being done generally. And I'm not generalizing, but I've been around long enough to know this isn't being done. And why should it's, who knows how to do this? Well, that's why you're here. I'm teaching you. So I hope that now it doesn't seem that complicated, because guess what? Now you can populate your table. So now we've got the adjusted risk for X-ray, and we see it's actually 6%, not 64%. And then we do that and then we keep populating it for all the other specialties. Okay, but this is a great way also. Now, look, interventional radiology is 7%. That's the highest risk. Well, then we've got to get in there. But guess what? That's where they do the proning. And that's what our formal risk assessment picked up on. So the minute we make it safer, when I come back in 6 months, actually, that should go down to 4%. Because right now, it's being confounded by the fact nobody knows what they're doing in their 2 prone, which was the whole reason I got called in there. But then I present this to the trust, my director, whoever. I've got solid evidence of what I'm doing is making a huge difference. All right. So this is the other thing, evidence-based practice. Because remember, your interventions are all fueled by case law analysis, legal analysis, policy analysis, literature analysis. It's evidence-based. You've done all the hard work. All you do is come back every 6 months and plug the numbers in, and you show a decrease. They should give you a bonus, and tell them I said that they should give you a bonus. Okay, good luck with that. So I hope you see what we're trying to do here. Okay, so this is just the equations for the CT room and the interventional radiology room. I've included the examples in the CPD handout, so don't panic too much. But that's how we're adjusting. So when I say unadjusted probability, I mean the raw score from the formal risk assessment. Adjusted is we've adjusted inside. We're comparing the X-ray room to every other service in radiology, and outside, and we're comparing to the trust overall rate. And that's why it's so sensitive, and that's why it's such a fantastic model to use. It will show every change you do. Because remember also, I've rounded up 2 decimal places. So if you want to, you can have 0.622211, but that will also show up when you on your interventions. So you might only be making a little bit of a difference, but you can measure it. So that's the other thing, okay? It can make it as sensitive as you want it to. So there's a great way also, like I said, to target the problem areas, and also to show a manager. And I gave a shout out to Gary, who went through this painful process with me, and he has firsthand experience. But the minute I showed him what we were trying to do, it became clear, I hope. And then being able to see what you're making a difference, in my opinion, is amazing in healthcare, because we don't get that very often. So you all know it's a legal duty. I don't really feel like I'm going to get into that. But what I will say is, people ask, I've had emails, what should the content of my MH training be? And I say, well, it depends, because your content should be driven by the risks you find in your trust or work environment or ward or building site or construct, whatever it is. That's what you should be covering in your MH training for the practical side. All right. And that says that in the law itself. If you read Management, Health and Safety at Work Act 1999, Regulation 3, 4, and 6, Management of Moving and Handling Operation Regulation says the same thing in Reg 4. So the content is actually driven by your risk assessments. So your risk assessments drive your content, because it's specific to the work area, which is why training in a training room generically, in my opinion, is the worst thing to do. We know that already, but I'm proving it now. It should be in the workplace where the risks are, so it's relevant and appropriate. Second question I get, is theory compulsory? Do you have to have theory training before you have practical? And I would say yes, but only in training someone how to risk assess dynamically using Tyleo and understanding the information you're giving them driven by your risk assessments, because that's the other big part of the law. Whatever I find in my risk assessment has to be disseminated to the employees, hence standard operating procedures, right? So we're now compliant. We are bulletproof as far as the law goes if we follow this method, because it's all driven by case law analysis. For my dissertation, I analyzed my law dissertation. I analyzed every single case decision by the Court of Appeal, the highest court in appeal that everybody else follows. And when an employee won, guess what? That's what I was reading. Why did they win? They win. And that's what my system is based on, to protect everybody. Because the Court of Appeal will tell you what you need to do. It doesn't tell you what the training has to have in it. It just says it has to be relevant and driven by the risk assessment and so on. Those are questions I've been asked over email. I haven't had time to respond. I hope that makes sense. Let's move on to the questions, if we can. Julie, do you want to take over there?
Yeah, no worries. I think we've only got one question. Thank you for that, though. Absolutely fascinating.
I was looking at chat.
So, yeah, there's a few things in chat, but the Q&A should have been the place for people to type in any topic-related questions. So we've actually got one from Simon Love, which is, did you consider using a slide sheet in conjunction with a PAT slide as part of your SOP for the lateral transfer?
You know what? Great question. And unfortunately, yes, I did write it in there. I also wrote how to use the slide sheet because, we used the tubular ones and so on. So yes, and also wrote in there, cover the heels, leave the pillow in. So yes, absolutely. Good question.
I'm just going to scan through the chat because I think a couple of people have put things in there as well.
Can we allow people to unmute and ask a question? Because actually I've left 10 minutes for it.
Rosie, I'm not sure if you can unmute everybody or if you'd prefer us to do it in the Q&A.
All questions to be directed to the Q&A box, please. That's what the Zoom function is on this webinar.
So I can see Jackie. Do you want to read that one, Julie?
Let's have a look.
On Q&A.
On the Q&A. So, Jackie, how does this apply to individual risk assessments in a client's home?
Great question. And you know what? I was talking to Julie about that. She's quite the expert on this, but let me give you my opinion. It's exactly the same. You are the subject matter expert. You go and, the minute I step on a ward, operating room, anywhere, I know immediately kind of what to expect. So yes, you can use this to risk assess a client's home. And I tell you why is because my consultancy firm advises private carers firms, and this is exactly what I teach them, exactly what I've just shown you, because it's the best way to. And then but the difference is you're now involving the client because in their home, and now we get into a grey murky area. If you say you need a hoist, that hoist, and they buy it with their own money, it doesn't need to be serviced regularly. So there's a whole host of other issues, but yes, essentially, yes, absolutely. Next one, Susan.
Susan McMillan. So safety checks on equipment used need to be identified on the risk assessment.
So anything that is manual handling related aid and doesn't move up or down comes under pure and needs to be serviced every year unless it's bought privately by a client, is the exception. Lola is anything that moves up and down, so hoists, forklift trucks, and that's every 6 months. And that should be included on your risk assessment. So when you do walk around, you notice they're hoisting a lot. Well, we better check it's plugged in, battery's working, they know how to safely get it down if it breaks. All that kind of stuff, absolutely. But that's why you tailor it to your ward. It's a great question. Absolutely. Yes, absolutely is the answer.
The next one from Emma. This sounds like a fantastic way of creating data to influence. However, we have a real challenge of getting staff to report injury or near miss. Despite lots of anecdotal reports in training or ward department and visits, this means it looks like our intervention is not needed. Any suggestions for other ways of data gathering?
Yes. Great question. So every SOP I introduce, and Gary can attest to this, as I also bring in a DATEX, standard operating procedure, that will tell you exactly what is reportable. And I make sure that everything is near miss. I saw something I didn't like. I didn't feel comfortable with this. I felt a strain. I now introduce a blanket policy. Everything is reportable via Datex. Usually it comes down to lack of education. People are scared. They don't want to cause a problem. So also your risk assessment should include what are the demographics of your staff. And from there, you can decide what if you need a Datex SOP or so on. But you're right. The other data is what you can do is you can look at HSE national rates, which is available. It takes a bit of digging, but you can come at a national rate which you can use in place of a trust rate. So the national rate right now is around 4.2%, I believe. So you can use that instead. And in my opinion, there's no issue with that because you're doing the same thing essentially. I hope that answers your question.
Okay, they're coming in thick and fast now. Fiona, I've been assessed to train speech and language students on manual handling,
right.
But the S&L department say they don't need it. How would you reply to that?
Well, who's the subject matter expert here? Right, the speech and language therapist. I don't tell them how to teach people to speak. The point is we're legally required to identify risks and then minimize those risks to a level that is reasonably practicable. So this method include that in your risk assessment, and you can artificially raise the risk to I shouldn't teach you how to weaponize these things, but of course it's going to happen. Because you're writing the variables to address the risk, I would make that a high risk that they're obstructing you. And that way you can escalate it to their manager, their director, because they don't decide, you decide. And again, that is driven by your risk assessment. So that's what I would do. But I understand. Yeah, you know what? That's a good point, and it happens all the time. But carry on.
Another one from Simon. If you're in a person's home, how do you compare with everyone else's homes?
Well, come around my house and you'll identify massive amounts of risk. But the idea is the same. If you have a client base of 20 clients and you've risk assessed for each client, boom, you've got your table. So you've now can compare using our table. So if you reduce the risk in one home, it's going to show that in your adjusted figures. If that it will show that you've adjusted for risk because it should go down. The point is, it's not a tick box exercise. Every patient's different. Every patient's a different size. Every house is different. Everybody's resources are different, but that will be included. And the lovely thing is when we take the average, it averages it out. It adjusts for itself in the model, and therefore you've accounted for it. So Simon, great question. I hope that answers your question. Use exactly the same method and quantitative analysis because it will adjust for itself naturally.
Okay. Sarah Thornton, going back to part one and looking at the variables, is there a minimum maximum number? Understand the 1 to 3 scores, a bit confused how to calculate the final score. Not sure how you got to 33.
Yeah, well done, Sarah. That was a test and you passed. So you officially can leave. No, I'm joking. Well done. No, that's a great point. So again, these are just examples, but what you do is you add up. So you add in so in Excel, so you do need Excel, it makes your life easier. Put in the maximum score attainable if you scored 3 on everything, and then that will be your overall score. So if it's 60, then from say 100, then you divide 100 up by 3 into low, medium, high. It's up to you. 33 was just an example. Looking at the various Talio, there's no minimum or maximum because it's customized to the ward you're risk assessing. It's up to you. You decide. But don't make it tick box. Don't make it too short. Because otherwise you lose the sensitivity in the analysis overall. In that table, you lose that analysis, that sensitivity. So good job. Yeah, but that's it. That's just an example, but you decide what's low, medium, and high. All right.
Next one from Simon. If equipment is bought by the client but is used by paid carers, does litigation not kick in?
Okay, so litigation is the process of getting compensation. Liability is what the litigation is going to prove. So my example is if the hoist breaks and it falls on the carer, they sue their employer, but the employer has no control over that piece of equipment being serviced. What you do is you train your employees to risk assess, and you've gone in and you formally risk assess, and you've identified that that is a risk, that the hoist isn't serviced. You can insist that it gets serviced because it's an identified risk. So that actually should never happen. So that question shouldn't happen if you do it properly, if that makes sense. You're covering yourself.
Okay. From Marta, do you have an example of an SOP to show us? For example, hoisting.
Yeah. You know what? I can send that out. If that's okay with you, Julie, I can send out an example rather than spend time explaining it.
No problem at all. Okay, Nicola, I'm a fully trained and experienced in health and safety for nearly 20 years in the NHS, but I come across many staff who state, what would you know? You're not clinical. Any ideas to combat this?
Well, I've got a PhD, a law degree, clinical qualification, and I get told the same thing. That comes in part 3, which is education in my knowledge mobilization conceptual framework. The first part of that is establishing credentials. And I put that in there because I'm saying I get it constantly. But unfortunately, that's part of the process. You have to show your credentials before the other person will accept the knowledge you want to give. And so, for example, my emails, under my name, I have all my letters. And it far outstrips anybody else. And I don't want to do it, but I have no choice. Otherwise, I show up and they're like, well, what qualifies you? But this way, that's one way to show that you are. So you could have your health and safety degree or whatever it is under your name. That's one way. The second way is, you know, the minute you start talking, people should realize, and they do realize, that you know what you're talking about. So just think in your head, and that's why part 3 is important, and I think I should present that, is that I show you how to overcome this, okay? Because they're trying to take the power from you in the power differential, but I cover that. And if you want, you can email me. I believe in the CPD, I put my email in there. So Nicola, please email me and I'll absolutely give you more information.
Thank you for that one. For Kurt, yes, the copy of the PowerPoint transcript, everything will be provided post-webinar. It's also recorded as well and available to all MBE members. Next one from Kay. Did you partially answer that previously? It was, as much as the numbers are crunching towards the end of your equations, they start off with a subjectional marking of 1 to 3 on the variables. How does that work?
Right. Well, again, that's a great question, actually. And the other question was slightly different, but this is, so what they're saying is, to make it clear, if I say that, if I watch them do it, and I think they're stooping a lot, I'll put 3, whereas my colleague might think they're not stooping that much and they put 2. So that's what she means by subjectional. However, this is not, so in law, there's there's 2 types of tests. There's objective, formal, and subjective. The objective test is always the preferred one. And that's why we adjust, because we are making it objective. So we go from subjective, absolutely agree with you. But when we adjust using without to the trust, we are adjusting for that subjectiveness. But you're absolutely right. But that's, again, comes back to be honest, Nicola's question. If you're a subject matter expert, then I highly suggest that you figure out where you are on the expert scale, because your subjective assessment is based on experience, evidence-based practice, and so on and so on. So that's why, yes, the formal risk assessment is subjective, but then we convert it to be objective in our sensitivity analysis. So you're right. Good question. That was really good, well spotted. But yeah, but we adjust for that. And that's why we don't confound. And that's why we don't want to confound, because you might, I'm one of those people who think the world's going to end tomorrow, so everything's 3, but you might be the opposite. So we adjust for that. So I hope that makes sense.
Fabulous. And then the last one again was around the SOPs, which we've already answered.
I'm happy to share it, but they're not templates because, it's just a way to how to write it, in my opinion. And but you should be conducting your own evidence-based research. Lovely.
Well, that was great timing. Thank you very much for today. And thank you again to Joanne's for sponsoring the event. Don't forget that the feedback form will be sent out to everybody, which you'll need to fill out and return to get your CPD certification. So if there's nothing further, any more questions?
Julie, can I just say one thing?
Of course.
Sorry, so Sarah, I want to. So I want to put out there also, since there's lots of people here who seem interested in this, I try not to work in isolation, and I'm publishing like crazy around this. So if anyone's interested in working with me around publishing and getting your name on a paper, all right, then in the CPD is my email me. I'd love to get some kind of national working group around this, and then everybody will get credit for it in anything we publish. So keep that in mind. If you want to, if you are interested in it, then let me know. Sorry,
we'll make sure that's okay. We'll make sure that your details are shared. Thanks again, and thanks for everybody for attending.
Great, thank you.